Welcome. This is Alyssa Saklak speaking, here to introduce our topic on mental health and obesity. I'm here with Alec, Timp, Casey, and Phillip, and we are here to talk about our research study. So over the course of this lecture, we will talk about our lit review, research question, implications, proposed study design, our target population, some more of our quantitative and qualitative data methods, as well as our IRB proposal. So part of our literature review on obesity and mental health showed that there was quite a bit of data out there and research on the comorbidity of obesity and depression. There was quite a bit of research showing how multidisciplinary approach can really help with the improvement of the separate disease processes, whether that's mental health or obesity. Yet there was very little research on the effective treatment towards the diagnosis together. And again, most of those studies were looked at independently. Another gap within the literature that we found was that there wasn't a ton of information on lower social economic status, which led us to our research question that we will talk about here. Again, we see quite a bit within the public health domain on obesity being one of our top leading priorities in public health. And our group found interest in looking at this a little bit closer and what are some of the solutions to this problem. Our research question is, does an integrative treatment program help decrease BMI and improve depression symptoms in adults of lower social economic status? So again, reiterating this gap within literature and within the public health domain is that we really wanted to see with an intervention of a synergistic care model towards obesity and depression, could this help improve depression symptoms as well as decrease BMI in patient populations affected by this? Implications for this study: this can be groundbreaking in how we approach care for obesity and mental health. Again, the evidence really points to treating each disease process independently. And we know that these are very comorbid disease processes that could really impact one or the other and which one comes first. And so we're hoping that with this research study, we would be able to better identify solutions, especially in those social lower economic status population. I will now pass it off to Alec to talk about the proposed study design.
All right, so how we plan to test our research question. We're going to use a randomized clinical trial. Below, we have listed the main inclusion criteria or participants that kind of meet what we're looking for. RCTs are the best gauge of how you test a specific condition directly. We're looking to eliminate any bias in the data, and we plan to do so with this criteria. Most of this is pretty standard for randomized clinical trials, such as eliminating vulnerabilities in specific subpopulations. But for this study, they just have to be above the age of 18, male or female, any ethnic group, classified as obese based on their BMI being greater than 30. They have to be clinically depressed, and this is gauged on the PHQ-9 scaling. They have to be moderate or higher. We're specifically looking at individuals that are below the poverty line, so they're in the low socioeconomic status, and they have to be willing to participate, which we'll get to this a little bit in a couple slides. Next slide. All right, so we're going to have 50 participants in this study overall. 50% of them, 25, will be randomized to the treatment arm. The other 25 remaining will be randomized to the control arm. We are going to track these patients over the course of a 6-month period, and we will do monthly follow-ups starting at their baseline. This will take place in both the control and the treatment arm. Our primary source for enrollment is going to be mental health clinics, and in order to remove any selection bias, randomization will be used. This is key, like I said, to remove the bias in the data. The IRB is primarily going to be there to protect the patients and make sure that the whole study uses the utmost use of ethics. And like I was alluding to, there's going to be monthly check-ins that kind of go over their vitals, and have them go through a couple of questionnaires. This is going to take place at baseline and then each month following until the study is completed at 6 months. In order to get to that point, the patients must consent to participate in the study. This is standard for any randomized clinical trial. They need to provide informed consent. This is the most important part of this whole process. And then following study conclusion, we'll then analyze the data to test for any significance. Next slide. All right, and then I kind of went over a little bit of the inclusion criteria. It's on the left. The exclusion criteria is then on the right, and it's kind of just any condition that would then exclude the patient from participating. It is important to note that if the patient is randomized to the control study, they will get these visits still, but everything else is just going to be standard of care. So whatever their current therapy was prior to this clinical trial is going to remain the same until it concludes. Next slide. All right, recruitment. So recruitment is going to be very heavily involved with the physicians at each mental health clinic. We need their buy-in because if they don't care or wish to participate, then this thing's not going to leave from the starting mark. So we really need to emphasize their participation, coordinating with them, and kind of hammer home that this is a crucial study and it's important for the well-being of our patient population. Marketing and outreach are going to be key approaches to make sure that physicians do participate and want to participate. And we'll make sure to emphasize that early on in the study. Next slide. All right. So then the main sources for data are going to come from the electronic medical record and physician schedule. Our plan is to use this information to know when patients are coming in, if they meet the criteria. It's all going to be heavily scrutinized, so we'll make sure that everything is de-anonymized, protected, so that there's no risk of the patient's data being breached or used for other sources. In the ICF process or throughout the entire duration of the study, we cannot use persuasion. We need to be completely objective and make sure that the patients are willing to participate and are okay with all the parameters of our protocol. And then, like I said, the protocol is the main source of information. So everything that is done in this study must refer back to the protocol or be kind of laid out, set out in the protocol. And next slide. And then I will hand it off to Casey to speak next on quantitative.
So for our quantitative data collection, our sampling approach that we used was propositive sampling. Our sample size consisted of 50 individuals that will be employed to evaluate the effectiveness of an integrative program on reducing BMI and improving depression symptoms in adults that are deemed to be of low socioeconomic status. So as, like previously mentioned, half of the population will undergo this program over a period of 6 months. The other half will act as controls and will be monitored and will have the same standard of care. So mental health clinics will be a primary source in terms of screening for patient enrollment. Mental health clinics will also have a maximum allotment of participants to enforce a diversified portfolio indicative of the targeted patient population. Selection bias will also be removed in the process through the means of randomization. So on to the next slide. So I will talk about the data collection methods in this slide. So the study will consist of a baseline visit that ensures that the subject is fit in terms of the criteria and voluntary participation, so informed consent. And the same data is collected at monthly visits and will be collected at baseline. So the assessments will include measurements of age, demographic, sex, height, weight, and the PHQ-9, which will be given to every participant. Monthly check-ins will take place for a period of 6 months, where we will evaluate the changes of the subjects. The inclusion of surveys performed at focus groups can help to determine the direction of the study and provide nutritional, fitness, and rest data that would not normally be collected during the clinical visit. Questionnaires will be given as well to evaluate self-awareness and any kind of mental changes as well. On to the next slide. So the sampling approach that we used, I've been mentioned before, was purposive sampling, and data saturation will be used as the guiding principle for the sample size. Both the control and intervention group will be kept separate during semi-structured interviews. And half of the population, 25 individuals, will take part of this program over a period of 6 months, while the other half will be monitored. There'll be no changes to their style. And then I will pass this now on to Phillip for the next slide.
Thank you. As we move forward in the slide, we're looking at some of our qualitative data collection and how we approach this. Our qualitative data is used to support our quantitative data and for us to explore deeper into it. As we look at our subjects, we will utilize a few steps for us to statistically analyze and to descriptively analyze our measures of frequency, central tendency, dispersion, or our variability. We will include measures of frequency by including graphs and tables to represent different variables and values. This will help give a better picture of what our qualitative data conclusions come to. Our key points will make sure that we do not create any biased opinions or place a push towards any direction in our research from what our patients provide us in our information. We will utilize an unadjusted analysis as well by conducting a hypothesis testing and complete sample t-testing to identify for covariates associated with the exposure and or the study outcome. Our conclusions will be derived on the efficacy of this integrated treatment program in decreasing BMI and alleviating depression. Next slide. One of our key points will be to also keep these surveys open-minded, keep our interview questions the same way. We want to make sure that this is utilized as an alternative data point, not as a focus portion, as our quantitative data will support the basis of our study. The questions will likely revolve around the topics of nutritional fitness and rest. Yet, we will have the subjects reflect on their experience, both good and bad, as we move forward in this study. We will ask that each individual keep a diary of how their fitness goes, how their nutrition goes each monthly, and how they feel that the program is functioning for their support. We will use varying sources of information to greatly clarify our data collection as time moves forward. Next slide. So one of the key items that we will use is a survey. Surveys are important because they provide questions that allow the patient or the participant to provide us with what they feel is functioning, what they feel is working, or what they have utilized in the past, so that we have a better picture as if they have used similar, or if this program actually pushes forward towards something that could focus towards our larger population. Some of the questions that we will address will be, what are you most proud of? What behaviors or tools helped you manage your mental health this month? What are some obstacles that you face? These are key points because as we move forward, the regular adjustments of life still are at hand, especially when it comes to mental health. Next slide. Next, we will look at our interviews as well. So our interview questions will be provided in a group form. They will help to provide our researchers in our group with different advantages of topics that can help us see a clearer picture for the group as a whole. Are certain individuals having different outcomes than others? Are there like-minded thoughts on certain things that may be causing a blockage with how they move forward? We will make sure that these are HIPAA compliant. We will ensure that we record these so that they can be transcribed in a way that we can utilize the data. Ideally, we want to make sure that we have at least 4 participants in each of these interview groups so that we have a better picture of what's going on and so that we have the best amount of data as we move forward. Some of the questions that we will approach are, what are your expectations in this plan? What has been going well with your treatment? Or what would you like to achieve? These are things that everyone will have a great answer on because everyone's here for a reason to move forward. Next slide. Alrighty, at this point in time, I will pass this off to our next presenter.
Yes. So for our data analysis, for the qualitative data collection, we decided to use the framework method to analyze the qualitative data from the discussions, interviews, and surveys. The framework method allows for us to generate themes and make comparison between different cases. So the framework method consists of 7 different stages: transcription, familiarization with the data, coding, developing a working analytical framework, applying the analytical framework, charting data into the framework matrix, and lastly, interpreting the data. So the framework method is a great tool that allows for us to achieve qualitative analysis because it provides a systematic model to interpret the data. This step-by-step approach and implementation of the matrix enables us to develop a more intuitively structured overview of the qualitative data. Next slide. So I'll pass this on to our next member.
All right, so the IRB, the Institutional Review Board, this is mainly used, like I said, for patient protection. And for this specific research project, we will be submitting a proposal for expedited review. The study is expected to begin enrolling at the 1st of January, 2024. And we hope to close the study July 1st, 2024. There is some give in this, but these are the preliminary dates that we have in place. Next slide, please. And as referred to earlier, these are a couple of the questionnaires, interview guides that we'll use throughout this study. Next slide. And this slide is just kind of getting back to protecting the patient at all costs. All their data needs to be protected, and it cannot be disclosed no matter what. A HIPAA compliant network will be used that's password protected. All data that is connected to each given patient will be de-identified, likely put into a subject number. And then other EMR services will be used to withdraw this data for this given study. Next slide. So then this is just going back to our informed consent. These are the pieces that must be a part of the ICF form. If they're not, then the IRB will not approve them. So we will go through kind of the components of our informed consent next. All right, and yeah, this is kind of just getting back to what I was just referring to. This is what our informed consent looks like. Next slide. Yeah. All right, and then that will wrap up this presentation.
Yeah, thank you for joining us today. I hope you had a great time.